So next we are going to discuss is the diseases of the blood. The first is the hemophilia. So it refers to group of the bleeding disorder that is caused by genetic deficiency in the clotting factor. We know clotting factor, it is essential for the normal blood coagulation. So hemophilia, it is a genetic disorder that will affect the blood ability to form clot. So this means that the people with hemophilia, they can bleed for a longer time than others after an injury, and it is usually inherited, and it is caused by deficiency in the one of the it is caused due to the deficiency in one of the clotting factor. So now this diagram, it shows how hemophilia, that is often X linked recessive disorder, and it can be passed from the parents to their children. Suppose a father with chromosome XY, that is a normal male without hemophilia, and a mother with XX chromosomes, she is a carrier for the, remember, she is a carrier for the, she has one normal X and other X is with the hemophilia gene. So there are four possibility of the children: son, so he gets the X chromosome from the mother, and Y chromosome from the father. And there are 50% chances the male at the birth would have this bleeding disorder, and a daughter, remember, she gets a normal X from the both parents, or gets normal X from the father and mother, that is hemophilic. So there are 50% chances of being normal and 50% chances of being hemophilic, that is with son, and with the daughter there are 50% chances of normal and 50% of being carrier like their mother. So that is why the hemophilia affects the male more often, as they have only one X chromosomes, and if that X has the gene for hemophilia, then they will have the disorder. Females can be carrier and usually do not show the symptom because they have a second normal X chromosome. Now hemophilia, remember, it is due to the deficiency of factor 8. So mutation in the gene for factor 8 that leads to inadequate clotting ability that results in prolonged bleeding episodes. So hemophilia A, it is caused due to the deficiency in the clotting factor 8. Now remember, when there is a deficiency of factor 8, the clotting process would be impaired, as this prolonged bleeding episode would cause, because the blood is unable to form stable fibrin clot. So remember, hemophilia A, it accounts for 80 to 85% of all the hemophilia. whereas other is hemophilia B. It is due to the, remember, it is also known as factor 9 deficiency or Christmas disease. Remember, hemophilia B is, there is mutation in factor 9 gene that impairs the clotting function that leads to hemophilia B deficiency. So deficiency in factor 9 leads to impaired clot formation and prolonged bleeding after the injury. The third one is von Willebrand disease. It can be either autosomal dominant or recessive. So we know the von Willebrand factor, it is synthesized by the endothelial cells. And the megakaryocytes. So it serves two primary functions. The first is the platelet adhesion. So this von Willebrand factor would bind and stabilize the factor 8 that is important for the formation of the fibrin clot. So remember, this von Willebrand factor binds to platelet receptors and to exposed collagen when there is a vascular injury, facilitating the adhesion of it facilitates the adhesion of platelets to the injured vessel wall. Other is factor 8 stabilization. So this von Willebrand factor binds and stabilizes the factor 8 that is important for the formation of the fibrin clots. So deficiency of this von Willebrand factor that leads to bleeding. Now, individuals with the bleeding disorders, they experience prolonged bleeding from the cuts, wounds, or even after the surgical procedure. There would be, remember, the hemarthrosis. That means, what is that? That is bleeding into the joints, like the knees, elbows, ankles. So why this bleeding occur? So that this bleeding can occur. The recurrent hemarthrosis can lead to chronic joint damage and joint deformity over the time. The individual, there may be also nose bleeding, bleeding gums, or heavy menstrual bleeding in the females, or there can be bleeding in the GIT tract. Remember, individual with a mild form of hemophilia or von Willebrand disease, they have clotting factor of 5 to 40% of normal. The moderate is 1 to 5% of the normal. And the severe cases when there is less than 1% of the normal. Apart from that, there can be chronic joint damage, repeated bleeding disorder, internal bleeding into the brain can lead to neurological complications, and it could be life-threatening. Now, what are the tests that are considered in hemophilia? Since there is a bleeding, that means there would be low hemoglobin that can be due to the chronic or severe bleeding. So the amount of Hb in the blood is proportional to the blood loss. The platelet count, they are normal, as hemophilia affect the clotting factor and note the platelets. So that is why the platelets here would be normal. Despite the prolonged bleeding seen in the hemophilia, The bleeding time test, that measures how quickly the blood vessels constrict and platelet they form plug, is often normal. Prothrombin time, it measures the extrinsic pathway. That is why it's normal in hemophilia. As this condition, it will affect the intrinsic pathway. Prolonged APTT. So APTT is often more than 2 to 3 times the upper limit of the normal in hemophilia. So this test will measure the intrinsic and the common coagulation pathway that involves factor 8 and factor 9. The clotting time, that measures the time it takes for blood sample to clot, and it is prolonged in hemophilia due to the deficiency in the clotting factor. The factor 8 and factor 9, they are low. So low hemoglobin results from chronic blood loss due to prolonged bleeding. The platelets, they are normal, as hemophilia affect the clotting factor and not the platelets. PT is normal as it does not affect the extrinsic pathway. APTT and CT, due to the deficiency in factor 8 or 9, so they are prolonged. So these tests can be done for the hemophilia. Now, what are the treatment of choice? You can give clotting factor replacement, infusion of recombinant or plasma derived clotting factors that can be given. In severe cases, remember desmopressin can be given. It stimulates the release of von Willebrand factor in a milder case of von Willebrand disease. For the joints, physiotherapy can be given. Or genetic counseling can be given for the families who are affected with X-linked hemophilia. Hemophilia A is managed through the replacement therapy with the clotting factor 8. Severe hemophilia is when there is less than 1% of the factor 8. Moderate hemophilia is when there is 1 to 5% factor 8. And mild is when there is 5 to 40% of factor 8. Apart from that, epsilon aminocaproic acid that can be given to inhibit the clot formation and inhibit the clot degradation and manage the bleeding risk during and after surgery. Other is the plasminogen deficiency, that is also known as hypoplasminogenemia. It is an autosomal recessive disorder that is caused by deficiency in the plasminogen, that is the precursor to the plasmin that helps to break down fibrin clots. Now, clinical features that is characterized by thick firm plaque and nodules. So these are prominent on the upper cheek and give a wood-like appearance. So eyes can be affected, gingiva can be affected, laryngeal mucosa can be affected. It is typically diagnosed in the childhood and occur in women. Respiratory tract lesions can occur, gingival lesions can occur. The treatment, it consists of replacing the plasminogen. So what are the current challenges in treatment? There is no commercial available plasminogen replacement therapy. Minimization of the mucosal trauma to prevent the fibrin accumulation. Next, we are moving to the anemia. Anemia is condition that is associated with decrease in RBC cells or amount of hemoglobin in the blood. So hemoglobin, we know it is an important as it carries oxygen from lungs to the rest of body. So when anemia occur, the body tissues and organ, they may not receive the enough oxygen properly. Anemia can be classified based on the various factors. First is decreased production of RBC. Iron deficiency anemia, it's the most common deficiency where the body lacks sufficient iron to produce hemoglobin. So there are a group of disorders like sideroblastic anemia that is characterized by ineffective iron uptake by developing RBC. Megaloblastic anemia, that is due to vitamin B12 deficiency, that is lack of this vitamin B12. Folic acid, lack of folic acid, that leads to impaired RBC. Anemia that is associated with chronic infections like TB, chronic inflammatory diseases, anemia of the inflammatory connective tissue disorders like in rheumatoid arthritis. Other is hemolytic anemia. So where the RBC, they are destroyed outside the bone marrow due to factors like infection, toxin, or autoimmune reaction, that could be the cause. Intrinsic cause could be like RBC structure or function when affected, like sickle cell anemia or the thalassemia. When there is a disorder of hemoglobin, that could be sickle cell anemia, where abnormal hemoglobin distort the RBC, leading to their premature destruction. Genetic disorders that result in abnormal hemoglobin production and RBC formation could be thalassemia. So what are the tests that can be done is RBC count, hemoglobin level, hematocrit, mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentrate, that helps to identify the underlying cause. Management depends on specific type and cause of anemia, like when there is iron supplement can be given for the iron deficiency anemia, vitamin supplements can be given for the megaloblastic anemia, and sportive measures like the blood transfusion can be given in the case of severe cases. So what are the clinical features of anemia? So there is, first of all, there is decrease in oxygen carrying capacity of the blood due to reduced RBC count. So patient will feel fatigue, feeling tired, weak. There would be inadequate oxygen supply to the brain, that may lead to headache, shortness of breath, as body fail to meet the oxygen demand. Dizziness occur due to the reduced oxygen supply to the brain. Pallor could be a notable sign is pallor, as evident in mucous membrane such as conjunctiva of the eyelid and oral mucosa. The peripheral blood smear, it helps you to visualize the size, shape and characteristic of RBC. Apart from that, sportive measures like fluids can be given to maintain hydration. Pain management, narcotics can be given. If there are any infections from the prophylactic antibiotics, they can be preferred. Other disease modifying therapies can be hydroxyurea. It stimulates the production of fetal hemoglobin that inhibit the polymerization of HbS and reduce the RBC adherence. Next we are going to discuss is the sickle cell anemia. Remember, sickle cell anemia, it's a genetic disorder that is caused by a change in the person DNA. Here, a thymine molecule, it is replaces adenine in the DNA sequence of the hemoglobin protein. So this change affect how hemoglobin, the protein that is present in RBC that carries oxygen, is made. So normally we know that hemoglobin, it carries oxygen smoothly throughout the body. But in sickle cell anemia, this altered hemoglobin tends to club together when it loses its oxygen, forming stiff rods inside the red blood cells. So this clumps causes the red blood cells to change their shape from the round to sickle shaped. So this new shape is condition is known as a sickle cell anemia. The sickle cell shaped are not only less flexible, but they also stick and break apart more easily than the normal red blood cells. So that makes it harder to carry oxygen and move through the small blood vessel. So the patient with the sickle cell anemia, they have symptoms like chronic anemia, like low red blood cell count. So these sickle cell will block the blood flow and damage to the organs. It occurs due to the reduced oxygen supply. Now the gene for sickle cell anemia is most commonly found in people whose ancestors they came from places where malaria is most common. That you have to remember for your entrance exam, like part of Africa, Mediterranean and Asia. So having one copy of the sickle cell anemia can protect against the malaria, which is why the gene has stayed in these population over time. What is sickle cell crisis? It is a major complication that occurs due to the sickle cell shaped RBCs, leading to severe pain and that lead to lack of oxygen, causing ischemia. So if ischemia occurs, that would lead to tissue death. Now crisis can be triggered by a factor like low oxygen, cold temperature, infection, dehydration. They are the triggered point. The people with the sickle cell anemia, they are more prone to infections, particularly caused by S. pneumonia. So that susceptibility is due to the, remember, spleen damage from repeated infarction. Even the kidney function and the eye health, they are affected. Now on the radiograph in the jawbone mandible, there is reduction in the normal bone pattern due to increased bone marrow activity. On X-ray, you would see hair on and appearance. It is also seen in conditions like thalassemia, etc. In the blood smear, the red blood cells would appear sickle shaped. That is the main characteristic of this disease. Now, how would you manage the sickle cell crisis? So, during the sickle cell crisis, which causes severe pain, you can give is the supportive care, adequate hydration, rest, and pain relief can be given with the medication like narcotics. So, children who are diagnosed with sickle cell anemia, we can give is the penicillin therapy to prevent the infections like against the S. pneumoniae. Avoid the triggering points that are dehydration, cold exposure, regular exercises, strenuous exercise. So these can be avoided. Apart from that, hydroxyurea can be given, that is used in adults with severe sickle cell anemia to increase the production of fetal hemoglobin. For severe affected patient, bone marrow transplantation can be done. Genetic counseling can be done. So these are all the methods that can manage the sickle cell anemia. The next we are going to discuss is thalassemia. Thalassemia, remember, it's a group of genetic disorder where there is reduced production of either alpha or beta chain of hemoglobin, the protein in the red blood cells that carries the oxygen. So these disorders, they are more prevalent in population from region from the Mediterranean Sea. That is why the name thalassemia is derived from the Greek word meaning sea. We know hemoglobin, it is composed of 2 alpha globin and 2 beta chains. In the thalassemia, the affected chain, it is produced in insufficient quantity that lead to the shortage of functional hemoglobin. So the excess globin chain accumulation with the red blood cells, it causes the structural abnormality that trigger the destruction by the spleen. The condition we call it as hemolysis. Now, what are the key clinical features that you would see in thalassemia? What you would see is microcytic hypochromic anemia, increase in effective production of red blood cells that lead to excessive bone marrow activity that causes the bone deformity, especially in the face region, facial bone, that results in chipmunk faces. The body, what it does is it try to compensate for inadequate, the body try to compensate for the inadequate bone marrow function by producing the blood cells outside the marrow that lead to organ enlargement. That could be hepatosplenomegaly, enlarged spleen and liver, lymphadenopathy, enlarged lymph node. So that could occur. Apart from that, this chipmunk faces, you would see on the X-ray is the prominent cheekbones and frontal bossing. That means that is protruding forehead. On X-ray, you would see is hair on and appearance of the skull due to the bone marrow expansion. Apart from that, the patient may experience delayed physical and dental development. Without treatment, there would be increase susceptible to infection, specifically the pneumococcal infection. The treatment we can do is regular blood transfusion that can be given to maintain the hemoglobin level, iron chelation therapy that can be used to prevent the iron overload from the transfusion, that can be done. Now, alpha thalassemia or beta thalassemia. Two types of thalassemia are there. So, alpha thalassemia, it results from the deletion in one or more alpha group, one or more 4 alpha globulin chain, globin chain. If there is deletion of one gene, it does not cause any clinical symptom or clinical problems. If there is a deletion of two genes, that results in mild anemia and microstosis. That means the red blood cells would get smaller. Hemoglobin H disease, if three genes that deleted, then it's termed as hemoglobin H. That leads to severe symptoms including hemolytic anemia, where red blood cells they get breakdown. There may be splenomegaly, enlarged spleen, and some patient may require splenectomy. And if there is a deletion of the 4 gene, then condition is hemoglobin Bart's hydrops fetalis. So here the fetus develops generalized edema and it typically dies after the birth. So patient with the thalassemia major, they require major blood transfusion to maintain the adequate hemoglobin level. Due to the excess risk of iron overload from the repeated transfusion, iron chelators we can use is the iron chelators. They can be either we can use is example is deferoxamine, deferriprone. So these are the iron chelator. What they do is they will help to remove the excess iron from the body to prevent the organ damage. So a patient with severe disease, we can do transplantation, HLA matched donor transplantation, by replacing the defective bone marrow with the healthier cells. Apart from that, genetic counseling can be done, surgical correction can be done for the facial deformities. That could be the treatment for your choice. The next condition we are going to discuss is aplastic anemia. So aplastic anemia, remember, it's a rare serious blood disorder where the bone marrow it fails to produce enough blood cells that results in a low count of RBC, that is anemia, low count of WBC, that is leukopenia, and platelets, that is thrombocytopenia. So it is, remember, it is immune mediated, where body immune system attacks the bone marrow cells that are responsible for the blood cell production. Other cause could be exposure to toxins like benzene, certain medications like chloramphenicol, or viral infections like the hepatitis. Now the patient with the aplastic anemia, he would develop fatigue, weakness, lightheadedness, decreased oxygen carrying capacity of the blood. There would be thrombocytopenia, leukopenia, that means there would be increased susceptibility to the bacterial and fungal infection. The thrombocytopenia may manifest as oral finding, as gingival hemorrhage, and mucosal petechiae. Apart from that, you would see is the purpura, ecchymosis, etc. Neutropenia that would occur due to the decreased white blood cells that would predispose to infection. On histologically, you would see inflammatory cells. The diagnosis is if there are fewer than 500 granulocytes per microliter, then term is neutropenia. If there are fewer than 20,000 platelets per microliter, then the condition is thrombocytopenia. If they are less than 20,000 reticulocytes per count, then there is a decreased RBC production. Now the treatment is supportive care, withdrawal of the causative agent like these toxins, medication, we can withdraw them. So removing the offending agent that may lead to recovery. Apart from that, the definitive therapy includes the bone marrow transplantation. Primary treatment goal is to replace the defective bone marrow with the healthy bone marrow from the matched donor. Now the successful outcomes, remember, they are more likely in patients who are under 50 years of old age with a matched donor. Those patients who are not suitable for transplantation due to age or lack of matched donor, we can give is the immunosuppressive therapy. Medications like anti-thymocytes globulin and cyclosporine that suppresses the immune system and induce the bone marrow recovery that could be given. The next condition is neutropenia. Neutropenia is defined as having less than 1500 neutrophils per microliter of the blood in the adults. Now conditions like genetical abnormalities like dyskeratosis congenita and severe congenital neutropenia can cause neutropenia from the birth. However, they can be acquired later in life, like the bone marrow diseases like leukemia, metabolic diseases like Gaucher disease, drugs, chemotherapeutic agents, antibiotics. They can cause infections like hepatitis, rubella, measles, HIV, autoimmune disorders like SLE, where the body produces antibodies against the neutrophils that lead to their destruction. Now the neutropenia, it increases the susceptibility to bacterial infection. For benign neutropenia, no specific treatment is needed. Treatment will include the supportive therapy, bone marrow transplantation, that could be done antibiotic therapy or recombinant human colon stimulating factor can be given, that is filgrastim. Hematopoietic stem cells transplantation can be considered in the patient with the neutropenia. The next condition is agranulocytosis. It is a condition characterized by a reduction or absence of granulocytes, particularly the neutrophils. So agranulocytosis, it typically develops rapidly within days of exposure to the offending drug. The patient would develop malaise, sore throat, fever, bone pain. Bacterial infection, they are more common. Red blood cells and platelets count are usually within the normal range. Orally, you will see necrotizing deep ulceration on the buccal mucosa, gingival involvement resembling the nug. Microscopically, you will see the oral ulceration with abundant bacterial organisms within the tissue. The treatment is discontinuation of the offending tooth. If agranulocytosis is suspected to be drug induced, you have to immediately discontinue the offending medication. The granulocytes, you will see, they will return to normal within 10 to 14 days after the cessation of the drug. Oral hygiene should be maintained. Chlorhexidine containing mouthwash rinses, antibiotic therapy, cytokine therapy, including the administration of granulocytes colony stimulating factor that can be given. So this condition is characterized by regular periodic reduction in neutrophil count due to mutation in the enzyme neutrophil elastase. So symptoms occur in regular cycles that last for 21 days. So recurrent episodes of fever, pharyngitis, oral ulcerations that can include the GIT tract, colon, rectum and the anus. Oral manifestation includes the ulceration, trauma to lips, tongues, buccal mucosa, gingival recession, tooth mobility, that could be the feature. So diagnosis you can do is complete CBC taken 3 times per week for 6 to 8 weeks to observe the cyclic changes in a neutrophil level. So neutrophil count should drop below 500 per mm cubic for 3 to 5 days, at least 3 consecutive cycles. That would confirm your diagnosis for the cyclic neutropenia. Medication is granulocytes colony stimulating factor that could be given. Corticosteroids, nutritional therapy or splenectomy can be considered. Other condition is thrombocytopenia, that is characterized by decrease in the blood platelets. We know platelets, they are essential for the hemostasis and as well as the clotting, the clot formation. We know the normal platelet count that ranges from 2 lakh to 4 lakh per cubic mm, but in thrombocytopenia this platelet drops below 1 lakh per mm cubic. So there would be impaired clot formation that would lead to petechiae, pinpoint hemorrhagic lesions, ecchymosis, bruises and hematoma, that is localized collection of the blood. You would see spontaneous bleeding from the gums, nose bleeding, that is term we use is epistaxis. Hemostasis is coughing up of the blood, GIT bleeding, and it can be fatal if in severe cases if the condition is below 10,000. Immune thrombotic purpura, it can be acute or chronic. Acute occur in children due to the viral infection and chronic occur in the young woman. Autoantibodies against the platelet antigen, that would these autoantibodies, what they will do is they will destroy the antigen in the spleen. So treatment, you have to identify the cause. You can discontinue the offending drug. The immune thrombocytic purpura, it resolves in many cases and require treatment with corticosteroids, immunoglobulin or drugs like thrombopoietin receptor agonist that could be given. In severe cases, a platelet transfusions or splenectomy can be considered for the treatment choice. To the vessel